In stroke rehabilitation, patients may regain movement, but not precise control, and current systems still cannot verify if their intended actions are truly executed. Respected judges, we present NeuroX, a hybrid EEG EMG digital twin framework for upper limb rehabilitation, a system that verifies whether intention becomes execution. Upper limb impairment is a major consequence of neurological disorders, especially stroke. Stroke is the third leading cause of death and disability worldwide, affecting over 93 million people. And up to 80% of stroke survivors experience upper limb impairment, particularly affecting fine motor control. This directly impacts daily activities such as grasping and object manipulation, leading to reduced independence and quality of life. Existing work combines EEG and EMG in different ways. Some use adaptive fusion for intention detection but focus on robot control without patient interaction. Others apply it to rehabilitation but remain limited to research setups without structured sessions or performance metrics. Systems for prosthetic control classify hand movements but are not designed for rehabilitation monitoring. And feature fusion methods improve accuracy but are purely algorithmic without a complete system. Across all of these approaches, one key gap remains. There is no system that verifies whether intention and execution are truly aligned within a rehabilitation framework. To address this gap, we propose NeuroX, a hybrid rehabilitation framework. We begin with EEG signals to capture the patient's motor intention, which is classified by our AI model as pinch or open. This prediction is visualized in Unity through a digital twin, providing visual feedback to the patient. In parallel, EMG signals are analyzed to measure the actual execution of the movement. We then synchronize EEG and EMG to directly compare intention and execution. Session metrics are stored in the backend and visualized on a clinician dashboard, enabling doctors to adjust prescriptions for future sessions. So, how exactly are we decoding the patient's intention? Our model performs robust, personalized decoding of EEG signals. Signals are pre-processed and segmented using sliding windows, then aligned using Euclidean alignment to reduce variability across users. Subject-calibrated models are well established in EEG motor imagery, and we build on this using hybrid covariance fusion, combining dataset and user-level information. Features are extracted using FBCSP and classified using LDA for pinch and open movements. This enables generalization across users while maintaining individual accuracy. So how is this model implemented in a real system? On the hardware side, we use a 8-channel EEG system to capture intention and a 4-channel EMG system to capture muscle activation, both calibrated per patient. On the software side, the system performs binary classification of pinch and open movements, with the output visualized through a digital twin built in Unity using C#, providing patient feedback. Session data is then processed and displayed on a clinical dashboard, with a TypeScript-based front-end and a SQL backend, enabling monitoring and analysis. Together, this forms a complete closed-loop rehabilitation system.
So now let's go through the session flow. Each trial consists of a 3-second cue, followed by a 4-second execution phase where both motor imagery and actual muscle activation occur. Then this goes to the AI model for prediction, which then reflects in Unity's arm movement, followed by a short rest period. This system then resets for the next trial, forming a continuous closed-loop neurorehabilitation pipeline. Now, to demonstrate the full system pipeline in action, let's take a look at our system video.
The system begins in a clinical setting where the doctor performs a calibration session and provides the patient with the NeuroX kit. The patient can then continue rehabilitation independently at home, guided by the system setup instructions. Once the system is set up, the patient initiates a rehabilitation session. Before starting, we perform EEG and EMG signal checks to ensure proper acquisition. The session then begins. During each trial, EEG and EMG signals are recorded simultaneously over a 4-second window, capturing both motor intention and muscle execution. The system evaluates performance in real time, displaying EEG and EMG accuracies for each movement. All session metrics are automatically recorded and stored in the backend. After completing the session, the patient provides post-session feedback on their experience. Both the session metrics and the patient feedback are securely stored in the database. These results are then reflected on the clinician dashboard, where the doctor can evaluate performance, provide feedback, and adjust rehabilitation prescriptions accordingly. This enables a more personalized and continuous rehabilitation process, reducing the need for frequent in-clinic visits to only occasional follow-ups.
Moving on to our AI model results, we compared two different training strategies: a dataset-only model using open source data and a subject-calibrated model with our collected data. The dataset-only model achieves around 85% accuracy in control testing, but performs poorly on our data due to high inter-subject variability. The subject-calibrated model improves to about 87%, and importantly, it increases the robustness on unseen subjects from around 50 to 60%. Overall, our model lies within the expected EEG range of 65 to 90%, but more importantly, it introduces execution validation, which most EEG-only systems lack. Now moving on to live system performance, we evaluate EEG, EMG, and the hybrid system. EEG is effective in capturing motor intention, but naturally shows variability due to signal noise. EMG complements this by providing more stable and reliable confirmation of actual muscle execution. When we combine both, the hybrid system becomes stricter by design. A trial is only counted as successful when intention and execution align correctly. So although the success rate is lower, it does not indicate weaker performance. Instead, it reflects a more realistic and clinically meaningful evaluation of true functional movement. Now to further analyze EEG behavior, we'll look at internal performance metrics. A decision margin of around 0.4 to 0.62 shows a clear separation from the decision boundary. Similarly, the class separation gap of 0.45 to 0.69 means that the model can clearly distinguish between pinch and open. Now this matches a graph where pinch stays consistently high above 0.8 while open remains low below 0.3 with no overlap around the threshold. Now for EMG results, the average onset latency is around 84 milliseconds, which confirms the fast muscle response, and the latency graph compares pinch and open gestures, where pinch shows faster and a stronger activation compared to open, which in contrast shows slower and more variable responses with weaker activation. So all in all, EEG ensures stable intention decoding, while EMG provides fast and reliable execution validation. Next, we analyze the synchronization between EEG and EMG. The system shows generally low synchronization error, with most trials tightly aligned. This indicates that intention and execution are occurring in a coordinated manner, which is essential for rehabilitation where timing directly influences motor learning. We also evaluate the system responsiveness through latency analysis. EMG onset occurs very quickly after intention, within a short physiological window. After that, there is a small processing and unity rendering delay, resulting in a total feedback delay of around 70 milliseconds. This low latency loop is important because it enables near real-time feedback, strengthening the brain-muscle connection during training. In terms of originality, our system introduces a synchronized EEG-EMG framework that not only detects intention but also verifies execution. So unlike the traditional EEG-only approaches, this provides objective confirmation of movement, making the output more clinically meaningful. However, there are still limitations. EEG signals remain highly variable across users, and the system currently supports only a limited set of gestures. Our future work will focus on expanding the gesture complexity, increasing the subject diversity, and moving toward clinical validation. So in conclusion, NeuroX closes the loop between brain and body, turning neural intention into verified physical action through a synchronized EEG-EMG system, enabling scalable, accessible, and data-driven neurorehabilitation.